Thank you. Yeah, I work with Southern Community Mental Health and just spent a few months with the Salem project team setting up the model of care for the new mental health rehab unit, and had the pleasure of working in that unit this week to cover a colleague. So it was fantastic to see that new facility open. So that's not my slide. Where do I go down? Yeah. Okay, let's see if that works. So I'm talking about some practical approaches that you can implement in your practice to optimise medications, and how these can support the equally well principles. That down button does not like me. Okay, so how can medication optimisation support equally well? By supporting people to take the correct medication, by supporting medication concordance, reducing side effects both long and short term, and management of psychotropic-induced chronic disease and management of psychotropic polypharmacy. So one tool that we can use to support people in taking the correct medications is by doing a best possible medication history. These are routinely done in hospital practice with pharmacists. However, depending on your service in a community, you might not have access to that, or you can access an accredited pharmacist who can be Medicare funded to do a home medicines review. A best possible medication history is a snapshot of a person's actual medication use at that point in time, and it provides an accurate list of their medications, and this can then be used to guide decision making about what to prescribe. There is a national standard that when taking a best possible medication history, that there are 2 sources at least, and this can include the person themselves or their carer, their own medications, a dispensing list from their community pharmacy or the GP list or any specialists, and the My Health record. Any historical adverse drug reactions or events and allergies should also be recorded in a best possible medication history, and it's important that these are updated regularly, especially before and after transfers of care and when there are changes in medications. So how does a best possible medication history help people? Well, the Australian Commission on Safety and Quality in Healthcare has published some data on this. Did you know that more than 50% of medication errors occur at transitions of care, and that patients with 1 or more medicines missing on their discharge information are more than 2 times more likely to be readmitted to a hospital than those with correct information on discharge? Furthermore, 85% of discrepancies in medication treatment originate from poor medication history taking, and between 10 to 67% of medication histories have at least 1 error, with up to 33% of these errors have the potential to cause patient harm. So best possible medication histories therefore reduce prescribing errors. They can ensure that people have access to the correct medications during hospital admissions and at transfers of care, and they can prevent hospital admissions and readmissions and ensure continuity of care and prevent medication-related harm. Other tools to support people to take their correct medications include medication lists, and there are some paper tools freely available on the National Prescribing Service website, including the medication list pictured, and that can be pre-filled out. You can print it out, the template, and then people or their carers can fill it out. Sorry, I'm trying to get this to work. There are some apps as well, subscription apps via the MedSafe or a free app through the NPS website again, and they're available to download on the App Store and Google Play. Supporting medication concordance is another medication optimisation strategy. So this can be inquiring about barriers for taking medications, considering whether supports for taking medications required, such as visual cues or reminders, so that could be around the house or on the fridge, in the kitchen. Medication alarms, like the one pictured, they can be timed to alarm at the times of the day that medication doses are due. Various dose administrations aids, so we might be all quite familiar with the blister style one pictured in blue where people push the medications through, and the ones from community pharmacies that some can have the days of the week and different times of day for doses that can be packed by a person or their carer. There's also the tab timers. These can be quite expensive. Not all pharmacies offer this service, but it basically can be programmed to release the medication at a certain time of day as well. Another, and as mentioned before, medication lists and reminder apps can also support people. Simplifying regimens where possible is a really straightforward approach. If someone's taking a medicine multiple times a day, maybe there's a slow release option available so they can take less tablets and reduce that pill burden. Education is another important part of supporting medication concordance, and this should be a discussion around the indication for the medication and side effects, and then followed up with provision of a consumer medicines information that covers what to do if someone experiences a side effect. We're really lucky in SA Health that we have subscription to Choice of Medications. It's a UK resource, and we've made this freely available and accessible to our patients and their carers. And this you can print leaflets that can be tailored to the health literacy of the person, and there's various languages as well, and lots of fact sheets about side effects and other things as well. The importance of constipation prevention and early intervention should also form part of any medication education. Most health services will have some local guidelines about psychotropic-induced constipation. The SA Health ones are freely available on the clozapine webpage. And talking about strategies for managing side effects should form part of this education, including any non-pharmacological approaches. And a common example that we use, if clients who experience hypersalivation on the clozapine, we may suggest using pillows to sleep propped up. Reducing side effects, both long and short term, is an important part of medication optimisation. So this includes that proactive monitoring that is recommended. So you're probably, for GPs out there, very familiar with the required monitoring requirements for antipsychotics, so cardiometabolic screening, FBE, liver, renal, prolactin levels, educating and screening for sexual and reproductive side effects. These should be done 6 monthly, as per your local clozapine guidelines. And then for mood stabilisers, therapeutic drug monitoring to ensure drug levels don't end up toxic and increase risk of toxic side effects form part of that. FBE, liver, thyroid and renal. Importantly, vitamin D and bone mineral density screening for some of these as well. So management of psychotropic-induced chronic disease can also support medication optimisation. Looking for signs and symptoms of these regularly, and then undertaking early intervention and proactive referral, and optimising that treatment and regularly reviewing for the various cardiometabolic diseases that we're all familiar with. With obesity, I think we should start thinking about the place in therapy for the GLP-1 analogue therapies if they're not cost prohibitive. If you look on the clinicaltrials.gov website, there are some trials occurring worldwide now looking at the place in therapy for mental health populations and people with schizophrenia, and it'll be interesting to see what data comes out of that. For some mood stabilisers, considering osteoporosis prevention with long-term treatment, we should be starting vitamin D and calcium supplementation as soon as those mood stabilisers are commenced. And the RANSCAP guidelines, or consensus statement, on physical health for consumers with complex psychosis. For those who do not engage with a GP, the management of all physical health needs should be addressed by a treating team. That can be challenging with the various resources of different services, but it's a consideration when we're looking at how we can improve our services moving forward. Management of psychotropic polypharmacy includes deprescribing those short-term or as when needed medications, and commonly in acute settings, benzodiazepines can be commenced for short-term use after admission, and same with those short-term antipsychotics. It's important that we review when they need to stop. And understanding that high dose and off-label prescribing of antipsychotics, so polypharmacy of antipsychotics, or more than one antipsychotic, or high-dose prescribing, it's off-label because it's not approved by the Therapeutic Goods Administration for that dose or combination. There's lacking evidence to support any benefit or safety. So it's important in these cases that we obtain consumer consent, document the plan for monitoring, and ensure follow-up on any adverse events and clinical benefit, and communicate this with other primary carers so they can alert the treating team if any adverse events do occur, and make sure, importantly, that this is done collaboratively with the person as well and documented, and just so they understand clinical indicators of response and the plans for review of ongoing need and benefit and risk for ongoing treatment. So thank you for listening. If you're interested for any resources to support medication optimisation, let me know. Cheers.
Thanks, Claire. Taking on a big topic.
Yeah, in 10 minutes, I know.
I'm sure people can come and speak to you if they've got questions. think you raised a number of the things that Scott Clark also raised in his presentation earlier this morning in terms of the use of things like metformin, thank you.
Yeah, GLP-1.
Metformin and the GLP-1
Yeah.
analogues, and how they're probably going to have a bigger role, but also highlighting, I think I'm taking Chair's prerogative at the moment, and the importance of managing constipation, and one of our dietitians talking about it before and things, and you know, it's just something that we can't avoid to, you know, it's something we should really pay attention to. But thank you, and I'll ask everyone to thank Claire.
Thank you.